So here's my disclosures. Unfortunately, none. Let me just start with a typical case, and I'd like to tell you about this case. And it's interesting. I saw this. I work as a neurohospitalist now, and I saw this right before the weekend. And this was the history we got, and this is the imaging that we received from the outside hospital. Obviously, a very simple story. Dr. Pizak will love this because, as you can see, this is an 89-year-old retired woman. She fell and says, "Oh, my right leg is numb." So, of course, the outside hospital gets an MRI of the spine, and you can see right here what is clearly an acute compression fracture. I'm just to kind of start pointing out spine issues with you guys. This is a level of the spine where everything is normal. It's up here. And you can see in front of and behind the little nerve rootlets there's plenty of room. There's nothing pushing on that. So that would be, say, up here. Down here, where this compression fracture is, you can see that these ligamentous hypertrophy and so forth has narrowed the spinal canal. This is severe lumbar spinal canal stenosis. Are we done here? What are you going to call the surgeon? Is that who do you call? Interventional neuroradiology to insert the glue? Do you call a surgeon? Who do you call? Anybody? You can't use your yes or no cards here. This is who are you going to call? Anybody? We have a surgeon. Anybody else? Does anybody want to call a neurologist? Yes. Why would you call a neurologist? You know what's going on here, right? I mean, have you heard of a simpler case than this? I don't know. I do not know why they called me, honestly. I don't know why they called me. But as usual, we walk in the room, and as I will review with you today and tomorrow, we'll talk a little bit about various aspects of the nervous system exam. When I walk in the room, this is a wonderful 89-year-old French lady with quite an attitude. In fact, I know the only French I know is "Parlez-vous français?" So I say, "Parlez-vous français?" She goes, "Well, yeah." She actually said that. She had quite the little attitude. But when she talked in French, she had just a little bit of a lisp, but her speech sounded a little bit like that. And I said, "Your speech sounds slurred." She goes, "Yeah, I noticed that too. I noticed that yesterday." Okay, so we take her through a full exam. We do some things like rapid movements of the hands, arm rolling, strength testing. And indeed, she has slurred speech, right upper extremity weakness. So I said, "What do you mean by your leg is numb?" "Well, I can't move it." Remember, she's 89. So they don't say, "I have iliopsoas weakness." They just say, "My leg is numb." What they mean by numb is weak. And what the primary service told us is that when they stood her up, she simply would not step forward with that right leg. Does that sound like numbness? No. You actually don't even know what it is, do you? So I held her. Do you mind standing up for me? I use you as an example. And you are Lindsay. From where?
Virginia.
Virginia, okay. So I tell this lady, I say, "Step forward." She doesn't step forward. So I hold her as hard as I can, like this. "Okay, step forward." And she walks just like this. So does she have a problem with leg strength? No, thank you. What does she have a problem with? Balance, believe it or not. Balance. So now we've got ataxia, slowed right hand movements, and imbalance with slurred speech. Where is her problem in the nervous system now? Yeah, thank you. Brain. And it was really that quick that we walked in, and the team was aghast. But what did they not do? They didn't make her walk. She said, "I can't." Okay, well then don't. Well, sometimes you've got to get people up. Here's a brain. This is a T2 flare, which we just call flare. And you can see all the capping of the ventricles. You can see some white matter changes there and there. Up until about 10, 12 years ago, this is all we had. And the neurologist would say, "I know this lady had a stroke." But now we have diffusion, and anybody can see this area right here, decreased diffusion right there, related to stroke in the left centrum semio valley. You can go to ADC mapping and see the stroke. This lady had an acute stroke. So this is an introduction to spine masqueraders. So this looked like and acted like and smelled like a spine problem until you get some more information. So I'm going to go through some of the tricks and traps and techniques that we use to help you determine whether or not you're dealing with a spine problem, whether you're dealing with another problem in the nervous system, all right? And I just put this up here just to kind of get you started, but we talk about the spine, right? Let me see here. When we talk about the spine, We could talk about the bone. So Dr. Piziak talked about compression fractures. That hurts, right, when you have a compression fracture sometimes. Sometimes it doesn't, so you have to be aware of what might occur in an 89-year-old woman that falls on her bum, as she would say. You could have ligamentous problems. You could have alignment problems, disc-related issues, root, cord, cauda. Any of these could be spine, right? And each and every one causes a different type of problem in terms of either pain or nervous system dysfunction. And the dysfunction, it could be orthopedic. So if somebody comes to you with back pain, where is the problem? Anybody? My back hurts. I was lifting weights yesterday, my back hurts right now. Where is my problem? Where would you guess my problem is? Yeah, musculoskeletal, absolutely. But people come in and say, my back hurts in the emergency department. It's horrible, horrible back pain. And immediately somebody says, my gosh, you must have spinal cord compression. Spinal cord compression doesn't cause back pain, does it? There are no pain sensors in the spinal cord or in the brain for that matter. So those problems, as you said, are orthopedic. And some of these orthopedic problems might be degenerative. You might have neurologic problems. When we talk about neurology of the back, you have the spinal cord, then you have the nerve roots, you have the cauda equina, which is made up of nerve roots. And the symptoms are different, and I'll review that with you. And remember, a lot of this can be psychological. A lot of people, their pain and their stress centers on their back, and they don't want to go to work, so they think they have a spine problem. So we'll be very careful when we talk about the spine now and in the future, because the spine could be a lot of things. The muscle, the bone, the ligament, the joint, the disc, the tendons, the cord, the root, etc. What I'll try to stress now as best I can, and this will carry through tomorrow, is that you have to ask. This lady's leg was, quote, numb. Even if it was numb and she couldn't feel it, we in neurology would always say, what is that? Sounds like a bowling alley, huh? Is this on me, is it? No? Oh, go on, okay. All right. Anything above that, does the arm bother you? The vision, the speech, the face, the swallowing, bowel, bladder dysfunction, etc. Ever noticed this before? I'm amazed in neurology to go in and the residents are absolutely stumped because somebody has some kind of change in vision or something, and you ask this person, this 30-year-old woman, she goes, oh yeah, I have this once a month. I have these flashing lights with zigzag lines. And you say, oh my gosh, you're kidding me. And these are just simple questions. Ask the above more than once. Ever had something like this before? Are you sure you haven't had it before? Well, I used to have it, but it was my left eye. Now it's my right. That sort of thing. How does this affect you? So when I say numb leg, fine. We'll start with numb. How does it affect you? Well, I can't put weight on it because it hurts too bad. Okay, it's really a pain problem. And then you're going to do a brief motor and sensory exam. You do not have to do a full exam. You're afraid of neurology, aren't you? Because there are so many tracks and so many nuclei and so many terms you don't know what they mean. And you're also afraid because you know the neurologist is going to make fun of you, don't you? I don't know why they do. They just do. Yeah, they try to trick you. I don't know why. So I'll show you today and tomorrow some techniques to kind of get over that. If you could do two things, you're going to listen to them talk like we did the French study and listen and watch them walk like we did over here and say, hey, how does it look? I cannot tell you how many times I've had patients say, I can't walk, and they say, well, okay, can't walk. Why not? Does it hurt when they sit up? Are they unsteady? Is one leg weak? Until you actually try to get them up or do get them to stand up, you are never going to know what they mean by that. All right. This is a guy, while you're turning this up, that languished in a rehab. What does rehabilitation mean to you? Get up every day and work on what you got so you can get more, right? Whether it's arm or legs or balance or strength or endurance or whatever, get up and do it. So he gets half of his foot removed because of diabetic issues related to infection. And he goes to rehab to get stronger again. And he sits in rehab. And the physical therapist walks in and says, all right, Mr. Jones, today's your first day in rehab. We're going to get after it. And he says what? When they say, I like that. That's pretty. Look at that. So, and they say, get up and walk. And he says what? I can't. Physical therapist looks down and says, wow, I just saved 20 minutes. Refuses physical therapy. I kid you not. 2 weeks this guy said this. I can't get up. Finally, an insightful nurse walked in and said, "Will you get up?" He says, "I can't." "What do you mean you can't?" "My legs don't move." My legs don't move at all. Zero movement in the lower extremities. 2 weeks he languished in rehabilitation. So he comes over to our hospital. We don't let him get away with "I can't move." We actually sit them on the side of the bed and watch their legs dangle at the very least. So listen to his story.
Here, as a couple of weeks ago, this leg I couldn't move, and now this one I can't move. No more.
Okay. Do you lose any urine?
A little bit, yes.
Okay. Have you soiled your pants at all?
Yes.
He's got bowel and bladder incontinence. Starting to sound like a spine problem to you? All right. Okay. Okay. Here's his exam. Straighten out your leg like that. Straighten it out at all? No. Zero movement.
Can you lift it up off
Not
the
even
bed?
anti-gravity.
Can you wiggle your foot?
And this is a list of his,
Can't wiggle his foot.
and y'all feel whichever one
Can you straighten this leg out at
may
all?
have.
Yeah, I'm sure I
Try to straighten it out that way.
All right, what's going on here? Does this sound like a guy that doesn't want to rehabilitate himself? No. Unfortunately, it might be too late to rehabilitate himself.
No. Can you lift it up off the bed?
And they offered a check.
No.
Can you wiggle your foot like that?
Okay. So you will know when to get
Nope.
over.
All right.
All right, now, look at his reflexes. Look how brisk that is. And somebody beat us to the punch. Somebody said, right, starting to smell like spinal cord, doesn't it? Bilateral extremiplegia, bowel and bladder, no pain. He's not complaining of pain. There's no roots compressed. And he's got hyperactive reflexes. All right, now if I ask you what level his spinal cord is compressed, you could make a guess. But I bet you could get even closer when I show you the next slide.
Oh, we know it. He was in ICU now.
Tell me when it gets real sharp.
Okay.
Whoa, right there.
Yeah, he had stomach surgery.
Tell me when it gets real sharp.
Yeah, I know about this.
Okay, when they did the CT scan for his
All right. So you're wondering why neurologists are sort of cynical. This is why. This is what we see most of the time, is something like this that's so obvious that every one of you gets it, but all you had to do was ask him or make him get up and walk and do an examination. So he's got about a T6 to T8 spinal cord compression. His story actually is a happy one, and I'll tell you about that in a second. So here is his sagittal MRI, and this is the cord. Behind the cord, you see that thick substance? You will not guess what that is. Anybody want to guess what that is? Kind of looks like blood, doesn't it? It's fat. It's adipose tissue. So people, when they get big or drink a lot of alcohol, will actually deposit fat back there. And he had spinal cord compression, epidural lipomatosis. The surgeon went out. Here's another example of it. See, look how much fat there is compressing the cord. He had that taken out, and within 3 months, this guy was walking again. So he did remarkably well. True story. You were there when I presented this when Dr. Chaput was there. Was this 6 months ago or 3 months ago, whenever it was? The back surgeon that did his surgery, they called him from the hospital one day, and they said, "Hey, there's this girl here, and she can't move her legs." And she says, "Because it's a bunch of fat in her spine." He goes, "Oh, come on, I've only seen that once." It was his sister. Absolutely. And he did surgery on her and had the same result. And true story, I wish he was here. I brought this guy to Morning Report with me one morning, which I do for the residents. So we're there at Morning Report, and I bring him in a wheelchair, and he sits there, and I tell him about his whole story, 29.5 minutes, and they go, "Wow." Finally, a resident raised their hand and say, "Well, how did he do after surgery? How did he do after surgery?" And he got up and walked across the room. It was like Lazarus. It was absolutely amazing. But nobody ever tried to examine him before that. So this is what we see. So when we talk about, and you guys can hear me okay, by the way, because I know I'm moving about. Okay. When we talk about the spine, really, we've got bones out here, right? We've got a disc. We've got ligaments. We actually have a facet joint that allows for movement with cartilage in between. Then you've got the spinal cord, and you've got roots that exit. So a spine problem could be any of those. So when we talk about spine, what do you mean? A compression fracture of the vertebral body, protruding disc, spinal cord compression, nerve root impingement, and we'll go over a bit of that today. All right, here's another simple one. I know you guys are going to get this one. This is a 74-year-old welder with left arm tingling and numbness. Here's his MRI, which was already ordered by an outside doc. And I'll let you hear the story, and I think we'll just send him to the surgeon.
I woke up when I got out of bed.
Oh, may have locked up. Let's see.
I woke up when I got out of bed. I thought I'd been asleep no more. You see what I'm talking about? You step on your.
All right, ready to send him to the surgeon? Oh, you've learned your lesson already. Okay. Do you want more information? Do you want to ask him if he has anything above or below the arm? Well, let's just let him talk. We'll just let him. I know we're busy with our electronic medical record. We have 14 patients in our waiting room. But let's just let him complete a sentence, for gosh sake. Are you okay with that?
Arm and feel, working, it gets okay. And I noticed it didn't get okay. And I went in to shave, and then I noticed that, see? Yeah, I couldn't feel it.
Yeah.
And I had a numbness,
Uh-huh.
Yeah, I'm numb, just right straight down.
Okay, right. Just awoke. The left side was numb. Just face, arm, and leg, and that's remained about the same.
Right straight down.
Where's this problem in the nervous system? Oh, yeah, you guys got it. You probably even know what his problem is. So he had a lacunar infarction.
I woke up when I got out of bed. I thought I'd been.
In the thalamus on the right. He just had a lacunar infarct. Face, arm, and leg. Very, very straightforward. All right. Here's another fellow that probably needs spine surgery. This is a 69-year-old retired rancher, pain and numbness in his feet. Fortunately for you, the outside doc has already ordered MRI of the spine. I'm going to show you this right here. Severe spinal canal stenosis. This is his imaging study. Severe lumbar spinal canal stenosis. Here's just a normal for comparison. You can see a lot of room. Sorry about that. A lot of room around these nerve rootlets. Nothing is being compressed in this normal comparison. But here, severely narrowed spinal canal. And let's listen to him.
It was like fire ants, or it's like it was when you was a kid and you cut off the circulation to your feet, and then it was like little hot needles running into them. That's the way they.
Can I just debunk a myth real quick, by the way? When you wake up at night and your hand is burning like hot needles, or your foot is burning like hot needles, why is that? That is not lack of circulation. Yes, it's nerve compression. You're leaning on a nerve. That's why when you take the pressure off, it takes about 2 or 3 minutes, and it actually gets worse, and then it gets better. If it was circulation, it'd get better immediately, wouldn't it? So when you hear somebody saying that they have tingling in the feet or in the hand, it is almost never circulation. Almost never.
At night, both feet did that. And one would try to see if it would out-hurt the other one. And we would rub them with this and that and anything, horse element, alcohol, anything. Yes, you can't sleep with it.
Okay.
I'm numb nearly to my knees.
You ready to send him to the spine surgeon?
I'd say it's about 6 inches of my knees.
What about in the hands? Any numbness or burning there?
Yes, I'm having it. It was nearly down to the first knuckle.
Whoa, wait a minute. Now, you don't remember a lot about neuroanatomy, but do you remember any nerve that goes from the low back to the hand? No? Then it's probably not a low back problem. All right, I'll give you guys one test that you can order on this man. One test. Glucose. We got an A1C, we've got a glucose. I'm going to throw out there, just in case the glucose and A1C are normal, and Dr. Piziak and I will spar on this, but I want a 2-hour glucose tolerance test if that's normal. I know, but that's just the way we do it. There's a little variation in practice here. A neurologist diagnosing diabetes, right? So, either way, this man is diabetic, and he'll...
Not as bad, but I can't button my shirt. I have to look at it to button it. I cannot feel the button in the shirt. I don't walk like I used to. I kid like I walk like a drunk man. I sort of wobble walk. I have no feeling to the balance of. I walk like I got false feet.
Close your eyes. Which direction am I moving it?
And I won't take you through his whole examination, but he in fact had diabetes, and this is a simple diabetic neuropathy. Now, how long has he had diabetes if this goes from his toes to his foot, to his ankle, to his legs, to his knees, to his hands? Years. Am I right there? Yeah, this is years and years. So he just probably doesn't go to the doctor and probably doesn't get his sugar checked and so forth. But Either way, this is a typical story for us. Now, before you order spine imaging, let me just point out a couple facts. So, imaging sensitivity is absolutely spectacular for diagnosing symptomatic back problems. Somebody comes in and they got a problem with the spine, and they got pain going down the leg, or they got paraplegia or something. You know, it can detect stenosis with CT 90% of the time, stenosis with MRI 90% of the time, herniated disc up to 100% of the time, depending upon the study. It is absolutely spectacular. That is not the problem. The problem is that it is also spectacular at diagnosing asymptomatic problems, which are of no use to you. So if we look at your typical greater than 60-year-old person here, a bulging disc 79% of the time, a degenerative disc 93% of the time. Now, how many people have you seen in your clinic that came in that are 32 years of age and said, I can't work, I've got degenerative disc disease? Have you seen that? Well, if you've been lifting things, like I think I was here for part of your talk, was it this morning you were talking about somebody lifting a car engine or something? What? A beer keg, even better. If you've been lifting beer kegs, right, and you're going to have some degenerative disc disease. You look at this. Mean age of 35, still up to 60% of people have a herniated disc, 20 to 28 bulging, and 72% degenerative. This is mean age of 35. So the problem with spine imaging is it's too sensitive, and it's not specific. There are reasons to suspect a spine problem. I don't know if anybody saw this game. This was in 1998. This fellow's the quarterback. This fellow is the defensive end. You don't know much about football, but this guy is going around the end, trying to get to the end zone. Theoretically, he would like his head to go with him. But this guy actually grabs the face mask. No penalty called on this play. No penalty called. So, and actually no injury. These youngsters are very, very resilient. You'll see things like this, or at least hear about them. You have to notice, you also have to know, you have to have a perspective of peripheral nervous system problems. So if I come into you and I say, you know, the top of my foot is numb, my thumb is numb, et cetera, et cetera, et cetera, you have to have those types of, here you go, those types of peripheral nervous system issues. Let's see if this will go.